providing a practical real-world implementation of the latest guideline approach in the management of IC. I came here in 2015 as a fellow, I guess part of my journey. Came here in 2015 as a fellow and actually started working in the lab with Dr. Bertha Chen. I'm not sure all knows her. And really early on, we started talking about radiation cystitis. She talked to me about interstitial cystitis. And I said, there's no way ever that I'm going to get involved with this condition. And I told her, if we do, then what's going to happen is everyone will start coming to you. And I think that's actually somewhat what's happened. At first, I never thought I would get involved with IC so much, but now really a large portion of my practice is consumed with this, which I've actually really come to enjoy. So I guess with that in mind, we'll go ahead and move forward. So some of the data that I'm presenting is not as hardcore data as some of what you just saw from our other panelists, but I just want to share some of my experience over the last, since 2015 in dealing, when began fellowship and then stayed on working with these patients and helping them reach their goals. So just some acknowledgements you can see here. I don't have any personal financial COI with our content. I also want to acknowledge all of our both former as well as current lab members. None of this work could be done without them, especially Dr. Mohammed, our postdoc in the lab, Mallory, who we work with the BT lab, Mallory Labule, our incoming resident, Dr. Amber Herbert, who will be doing her research here with us. We've actually submitted a proposal to the SWU, currently in review. Our medical student, Sade Sinclair, our Med Scholar student, so with us for this year, and also international scholar Bernadette. I want to thank you all for being here, as well as all of our former members. For those that are interested, here's our lab website. Sorry, just a little free advertising here. We do have a research mission statement. It's to improve quality of life in patients suffering from bladder dysfunction, and also a diversity statement. We find diversity is very important, and the diversity of experiences allows us to apply a diverse approach to solving problems. And some of our focus, as you've heard earlier, is oxidative stress with this IC. Our other pillar is actually nocturia and circadian rhythms, which that will have to be a different grand rounds. A case vignette here, I'm not going to read into this in detail. We work closely with the bioengineers in the Bio E141 course for several years, and have used both nocturia, urinary tract infection, and IC BPS as a part of our cases that we provide them to help identify needs. Among common neurologic conditions, this is from the Urology Care Foundation, IC, or I'll refer to as IC, pops up as one of our most common and important conditions, and most frequently encountered conditions that we may see in practice. This is taken from a huge list of almost all urology conditions from A to Z. IC was actually, it's been frequently the topic of the NIH. I was fortunate enough to join this consortium back in 2022, which forms some of the basis of what we're doing right now. Our research emphasis, a lot of this is focused on IC. We are also focused on some interest in urinary tract infections as well as nocturia and circadian rhythms. And our learning objectives for this talk will be to provide a practical and systematic evaluation approach to patients with IC BPS, and also to clarify some more of the updates from the latest 2022 AUA IC BPS treatment guidelines. This may be helpful for your boards, and also very helpful for any of those that have not read through all of what's most recently been updated. So setting and realizing patient objectives. So just some introduction to this condition. So I think one of the most important things is this is actually a clinical condition. It's a clinical syndrome. The diagnosis is made, though, after ruling out other identifiable causes of bladder pain. The definition hasn't changed much in the guidelines over the years, but we do want to exclude other things from our differential, including, of course, overactive bladder and some of your other things you see here on our table of differential diagnoses. And they purposely set the duration of symptoms to be more than 6 weeks duration. Some of the other definitions have been more strict and more long, but they found that those exclude certain populations, certain patients from even seeking treatments, according to this. We actually recently published a paper on distinguishing the IC from OAB. And I think one of the common things between these conditions are both the presence of storage and lower urinary tract symptoms. This was in neurourology last year, or now 2 years ago. But the key distinguishing feature for the IC is the presence of the bladder pain, whereas OAB may have urgency incontinence. Giving some practical use for our clinicians who are facing patients, painful bladder filling. This could be something that you directly ask your patient to help localize really where's their discomfort coming from for their symptoms, or painful urgency. Both of these were taken from Lai et al. Journal of Urology, and that can be the urgency to urinate, mainly due to the pain, pressure, or discomfort instead of just a fear of incontinence. Pathogenesis, we've heard a lot about this today. I'm not going to belabor this, but can include inflammation, autoimmune dysregulation, bacterial cystitis, urothelial dysfunction, deficiency of the gag layer, as well as a urine cytotoxicity, but a common theme here is bladder pain. Epidemiology from the RAND interstitial cystitis epidemiology RICE study. For adult women, it's around 2.7, 6.5%, or at the time of this study, published around 3.3 to 7.9 million in the United States. The male population is a few fold less than that, but actually it may be underdiagnosed in male given the close overlap between chronic prostatitis and chronic pelvic pain in men. So our urology perspective, so 2011 was our original IC guideline. That was the culmination of literature review from 1983 to 2009, followed by an update in 2014 with 31 additional studies, and a more recent update in 2022 with 53 additional studies. Do we have someone monitoring the chat in case there's questions from the chat? And also, if there's any questions from the audience, please raise your hand or start clapping, and I'll break this up from just being a monologue. So you know I'm a very interactive person. So some key guideline changes here. So in 2022, they actually moved away from calling things first through 6 lines of tiers to actually having these 5 treatment categories. So you have behavior, non-pharmacologic, oral, intravesical bladder installations, procedures, and a major surgery. We've covered several of these, including some of the adverse events from pentosan polysulfate sodium. Also included is some new guidance on patients with Hunner ulcer, and the major surgery section was also completely revised, which we heard about some highlights from that. Here's the typical AUA nomenclature for the level of certainty and evidence strength. And here's just a look between the 2014 versus the 2022, which you can see here on the right. There's in the 2022, the use of cystoscopy to identify patients with the Hunner ulcer, as we can actually offer different types of treatments. So I want to ask everyone, are you feeling in the weeds right now when you're seeing your patient with IC? Stuck in the weeds. So this is just a term that can have different meanings, as synonymous with feeling overwhelmed or focused on a current problem or a situation. It can be easy to get confused trying to work up these patients. They can present with just a whole variety of different symptoms and expressions of their experience with their condition, and sometimes even hundreds or thousands of pages of records. So my goal today is to help you get out of the weeds and give you some practical, real world tools that you can begin using tomorrow. I won't read through all of this, but our diagnosis includes a basic assessment, careful history, physical exam, laboratory exam. We should also assess baseline voiding symptoms, consider cystoscopy and or urodynamics when the diagnosis is in doubt, and cystoscopy should be performed in patients who we suspect Hunner ulcers. So first one, we'll have a summary very at the end, get out of the weeds. So something I like to do to help clarify when we're assessing these patients is try to identify flare triggers. A lot of these patients, their symptoms may come in certain, we'll call flares. It could last hours, it could last days, weeks, etc. Common triggers that can be common among patients include stress, dietary or certain food triggers, environmental acidic foods, bladder holding, some sort of pelvic intercourse, and also seasonal. So this is something that can be very useful and also can help you find different recommendations for avoidance of flares if you can identify the triggers. Other things that are very helpful, again, get out to the weeds, is trying to quantify procedure pain using some sort of numerical rating scale. I recommend the 0 to 10 numerical rating scale. We began using this around 2019 with one of our former fellows, Ravine, that devised this current questionnaire. It's important to ask patients about their experience with prior instrumentation of the urinary tract and just ask them, what was your pain experienced when you had a cystoscopy? And if they say it was 10 out of 10 pain, it's probably not a procedure you can easily do with a patient in clinic. Other things, use the physical exam is very important. Getting out to the weeds, using the pelvic exam, both female and male, we can assess pelvic floor muscle groups as I've noted here. Also, we really need to assess resting tone, contractility, relaxation, and also in both male and female, we can assess anal sphincter, resting tone, contractility, and relaxation. For women, unique to them, we can assess the male meatus, urethra, bladder neck, trigone, apex, cervix, and adnexa for any kind of potentially bladder-centric pain, and in men, the prostate. So what else to help you get out to the weeds in your assessment of your patients? Some patients during pelvic exam, we may choose to do a straight catheterization. For instance, if the diagnosis of the post-void residual volume is in doubt, or if we want a more sterilely collected urinalysis specimen. If we are doing this, something we really like to do is actually ask the patient, what is your pain score with the straight catheterization from 0 to 10? And we found close correlation that those who aren't able to tolerate straight catheterization actually aren't able to tolerate the office cystoscopy very well. Other things, we actually were able to put together a really nice series just from our own series of procedure pain score, and looked at 314 cystoscopy procedures we performed over a 3-year interval. We actually didn't find a difference in sex difference. These are for patients who tolerated the office cystoscopy, with a mean pain score for diagnosis cystoscopy of 2.87 for male versus 2.89 for female. So cystoscopy. So we should perform this when there's concern for Hunner ulcer. So cystoscopy, especially if patients are failing their prior therapies, there is, and this is specifically in the latest guideline, odds of finding Hunner ulcer higher over the age of 50. So those patients, you may have a low threshold to want to offer a cystoscopy, but we don't recommend a cystoscopy for every single patient. How else can we get out to the weeds and really try and find some objective data? Get a bladder diary. This is our bladder diary, which anyone's welcome to use using this QR code, just download from our website here. But some key things are measuring intake volume, type of intake, also volume of void to get an idea of their diurnal variations in their bladder capacity, and also look at their urinary frequency, any urgency. And we also quantify pain with this diary. And I think the really important here is before we started using this specific version, we would get 1 day of diary, and that could be four or 5 pages long. Because some of these patients, just for each entry, they keep writing another line, and those are really uninterpretable. So with this, we have the pre-filled in times. So if patients are having multiple voids per hour, they can just separate each entry with a comma. Very simple things, but really can help sort out things with these patients. What else? What else have I found to get out of the weeds? Standing urine cultures we've found have been very useful. For patients who truly have IC, the bulk majority of these cultures are going to come back negative, and they're very easy to manage. If they do come back positive, this is a really great way to accumulate interval data between each. I'll try to see patients annually, and we can look at the data to see what's come back with the next year. And if you have a lot of positive urine cultures, we really need to question what the actual diagnosis is for the patient. So found this useful, and also using Peridium, which you can use 100 to 200 3 times a day for 7 days. Patients will take on their own for a flare. Oh, I heard a question. No. We'll carry on. Management, so really using shared decision-making is crucial. We need to look at efficacy of treatment periodically and remove ineffective treatments. Multimodal pain management is also important. And if there's no important improvement after multiple treatments, we really need to reconsider the diagnosis. Another thing I've found useful, and anyone can turn around and start using this practice tomorrow, is really focus on your AUA symptom quality of life score and use that as a barometer, and use that to try and assess patients' level of satisfaction with the bladder each visit. And particularly in counseling patients who report being mixed on the quality of life scale, they could go either way. And then if a patient is consistently saying they're 0, 1, or 2, or mostly satisfied or better, I'll often advise them that, just stay where you are. Whereas if they're consistently higher on the scale, we can use that as a tool to help gauge their expectations. And then from our Stanford ACEs coaching, something else we've found is that one question I've found that's really helped to narrow things on these patients is really ask the patient, what is your objective for today's visit? They'll come in with a 1,000-page record, but what is actually their objective from that? So kind of really quantifying that for each visit can help focus things in your assessment. Not going to read all of this, but this is our new category, is treatment behavior non-pharmacologic. The education, I think, is very important. Self-care practices, stress management, and also physical therapy falls into this category. And specifically, and this is something we'll see a lot of patients may have been advised from the community, but really these patients with IC, we should try and avoid the use of pelvic floor strengthening exercises. They should be avoided. We really want to focus on techniques that decrease the pelvic floor tone. Stress reduction, how can you do that? That's if a patient knows what their stressors are. Something also Dr. Hanno really swore by are these warm tub baths. It sounds like they really work for certain patients. Higher level of stress are related to greater pain and urgency in patients with IC. And also this is associated with maladaptive coping mechanisms and pain catastrophizing. So 3 different phases related to that include the rumination, magnification, and helplessness. I've also found that it's quite useful, if I think that this is going on, to make referrals for CBT or cognitive behavioral therapy. There's fairly strong evidence on the use of that. Dietary modification, I think. Oh, yes, please. Thank you.
Do you have any specific mental health providers that you like to work with?
Oh, that's really great. I believe that's Tope. Dr. Rood, excellent question. I don't have a specific. They actually updated the form for making the referral and actually removed a lot of hoops. A few years ago, we had to almost be our own psychiatrist and write everything they needed. But lately, I've been able to just request therapy and through the standard referral. So, but no, I don't have a specific provider. So,
and sorry, one follow-up question. When you're encouraging a patient to, sorry for the background noise, encouraging the patient to do CBT, and what do you counsel them in terms of expectation for timeline and efficacy?
Patience. I recommend patience. Patience is a virtue for patients. I would say I think it depends on how long the condition has been present, whether it is in the chronicity. But I would think on the order of months to years. So would be my opinion. So, any other thoughts on that? Great. We'll move, and here are just some things we can recommend for dietary if you're trying to find. We usually recommend switching over the least bothersome list here, and then patients can slowly add back to help identify some of their dietary triggers. Oral pharmacotherapies, those were moved into their own category with this latest version of the guidelines. Regarding pain management approaches, urinary analgesics are often preferred, as well as the NSAIDs or Tylenol. And we really want to, if we can, avoid opioids. Some certain, especially if patients admitted for a pain flare after a hydrodistension, we may use them, but really try to avoid that if possible, just given the non-specific nature of a lot of the opioids. it is a major concern. Others that are included in our guidelines are the amitriptyline, cimetidine, hydroxine, and the PPS. Just some practical use on these and their evidence strength, and for comparing AUA versus the international consultation and the EAU in another large review. Maybe I won't go into all of this here, but amitriptyline, really we use it at a fairly low dose, and a lot of patients can get by with this. There is a fairly high side effect profile with this, especially can be bothersome dry mouth, constipation, but a lot of patients, if they can get far enough into their dosing, they're able to usually get over that. It gives a grade B for evidence from the AUA, a little bit lower or similar grade B from the ICI, A from the EAU. So some of the stronger evidence compared to maybe these others, probably the other that I use more, among these 4 options is hydroxyzine, which gets a grade C. It started at a dose of 25 milligrams at bedtime, can help with sleep, and also patients who have concomitant allergy symptoms, which those may also benefit from that. That, though, gets a grade D from the ICI and an A from the EAU. I think harm is relatively low potential harm with this, so can be a great option for those with nocturnal symptoms. And then the PPS, which you heard about earlier, it is our only FDA-approved pharmacotherapy approved for this indication in 96, so it's about time for something new, but does carry the risk of the hyperpigmented retinopathy. So again, kind of my get out the weeds, I really like to try to classify the dominant symptom if we're thinking about oral pharmacotherapy, and really ask the question, are you bothered to the point by your symptoms that you would want to take an oral medication? And really use that quality of life scale to help drive their decision whether or not they want to pursue a medication. That sleep, if that's a dominant phase of the symptom bother, we'll try hydroxyzine, pain, amitriptyline, or if they're refractory or intravesical or more dietary, may pursue Elmeron with all the cautions we mentioned earlier. Not going to go into this. This is just actually a picture I found of what this hyperpigmented retinopathy looks like. If symptoms can include, and you can ask patients about this at baseline, difficulty reading, slow adjustments to light, blurred vision. This is a fundus exam on left and right eyes, A and B, also a wide field autofluorescence. And I think you can see here some of what's going on with that. Not going to go into this in detail. Probably the biggest thing is with the AUA guideline update, is they added the FDA-approved new warning label for PPS that came out in June 2020. And they recommend a detailed ophthalmologic history, baseline retinal exam, and then retinal exam 6 months after initiating periodically. Won't go into too much detail on this. And then looking at the intravesical bladder installations, main categories from guidelines are DMSO, heparin, and lidocaine. There are other various cocktails that can be used. As far as grades of evidence, DMSO, this is our only other FDA-approved pharmacologic, and the only intravesical pharmacologic approved in 1978. It's a 50% dimethyl sulfoxide and 50% water. Tried to hold in the bladder for 15-20 minutes. It can be instilled as part of a cocktail. In real world use, I find this is very hard to get approved by insurance, is a big challenge. So it's only a fraction of my patients who may use this. Heparin gets a grade C, can also be used in combination with the alkalines like lidocaine. And also lidocaine can be used. And then another get out of the weeds moment to provide some clarity. The ICA, I'll often refer patients to this site to look at a lot of great patient educational material. But ICHelp.org is from the Interstitial Cystitis Association, and they have a variety of different cocktails that patients can read about. Some certain themes, the Moldwin cocktail. The Whitmore cocktail is probably what I might use the most. Moldwin cocktail, all those involve gentamicin, so there is that confounder about infection. And also gentamicin can be hard to come by at certain times of the year if there's a shortage. And then the other on here is, pain cocktail too. Both of these involve the DMSO. So if we're having problems with getting insurance coverage or gentamicin shortage, usually we can get the agents that are in the Whitmore cocktail I've listed here. but feel free to check that out on ichelp.org. So who do I offer these to? Well, certain criteria. So patients need to be able to tolerate intermittent catheterization to deliver the medication. If they do have dysuria after getting the medication, you can also use intermittent catheterization to empty the medication from the bladder. Really, they need to be able to have the ability and capacity to hold installation for at least 15 minutes. For practical implementation, you can give this with your APP in clinic on a weekly basis, potentially for 6 weeks, but there's a lot of alternative schedules. And also I found it useful as a flare treatment, and especially useful, my patients are on this for long term. If they can perform their own self-administration, that can be the most successful. Other treatments, the cystoscopy hydrodistension, this carries both a diagnostic and a therapeutic effect. Our diagnostic effect is that we can help the disease staging, measure anatomic bladder, anesthetic and anatomic bladder capacity. And this can serve as almost a benchmark for what we might want to get a patient to as far as their functional capacity. Therapeutic effect, again, we don't entirely know what the exact mechanism of action is from the therapeutic standpoint, but it likely has mechanical effects by allowing the bladder to be held at its anesthetic capacity while the patient is fully anesthetized, and you've disconnected that bladder-brain connection. Some get out of the weeds moments. First thing here is just stay out of trouble doing your hydrodistension. I know it's one of the most simple procedures in all of urology. But if you are going to do a lot of these, I recommend really trying to standardize these. So if you want to go back and compare all your findings and also compare within patients how you're doing. I'm not going to read over all this, but things we also look for potentially would be involuntary motor and vital sign changes, as these are often indications of maybe a more severe case of IC. Also documenting the pressure in the correct unit. See a lot of operative reports. This is just made for future residents. Just be careful. Our unit of pressure is centimeters of water, not millimeters of mercury. There's no mercury used in the pressure measurement. This isn't blood pressure. And never perform the intradetrusor injection or a biopsy. This is more my opinion, but before hydrodistension due to the increased rupture risk. I've seen this on a lot of referring reports, maybe just as a typo, but hopefully not in real practice. And then our standard, or at least from guidelines, they recommend duration of less than 10 minutes and between 60 to 80 centimeters of water. At least the standard I've implemented for all of mine is 60 centimeters and 8 minutes. And we'll measure the height of the water using an actual measuring stick and watch until the gravity inflow stops, and then just hold it at that volume for 8 minutes and talk about IC. So everyone has heard all of this. But then some other key things, something I would recommend for everyone is really try to become more descriptive over what you see on your cystoscopy report. So not just is it a bladder tumor, not a bladder tumor? With the IC, there's still a lot we don't entirely know about the different features, what we're looking at in the bladder. There can be fissuring, there can be inflamed, non-inflamed, classic, Hunner lesions, this waterfall hemorrhage, submucosal hemorrhage. All of these are important findings to describe. I would really try to encourage everyone to move away from the term just erythema, because that's not very specific. Another thing that's come up fairly recently within the literature is this terminology of both the active versus hidden Hunner ulcer. Active Hunner ulcers are those that are already just ulcerating even before the bladder is distended, just upon entry. And then the hidden Hunner ulcer, these are those that are only apparent after the bladder has underwent the hydrodistension. And other key things to quantify glomerulations, telangiectasias, fissures, terminal hematuria. All these are great buzzwords that may be associated with the condition. Also important, don't forget that if you do see a finding concerning for Hunner ulcer, if the index of suspicion is high enough to be concerned for some sort of malignancy, then a biopsy would be indicated. And you can also ask your pathologist to do a tryptase stain, look for mast cells, and quantify that. And if they are present, these can actually respond fairly well to fulguration. Per guidelines, you can use laser electrocautery. We tend to just use electrocautery just for simplicity. And then also triamcinolone injection can be also performed. just in my own practice for the triamcinolone, I usually won't do this on the first identification of a lesion because really want to kind of watch it after a fulguration and see how it responds. But if it is used, it's used 40 mg per ml, 10 ml, 400 milligrams divided into 10 to 20 injections, like to use this Coloplast 70 centimeter needle. Cyclosporin A, this is a calcineurin inhibitor, interferes with IL-2 T cell lymphocyte activation. The data here, while this was a major change in the guideline that, they made this whole separate section about the Hunner ulcer. I'm hopefully with Ashu's future research into ROS, we can become more specific about this because this medication actually carries just innumerable side effects. And the studies on this are still relatively small number of patients, as you can see here. Our IC dose is usually 1 to 3 milligrams per kg per day. There's a lot of potential side effects. I will monitor these patients, but under the supervision of the administration with either rheumatology, immunology, or transplant, just because they're more familiar with the dosing. But to track patients, I'll see them annually, but have them keep quarterly bladder diaries and send those in to us just so we can track them. But a number of other side effects and other common uses for this medication. Cystoscopy and Botox. This is not FDA approved for the IC indication, but many patients get the OAB indication for which Botox is approved. I'm a little more conservative and may say that there's a risk of retention around 9% extrapolated from the OAB literature. The risk of retention may be somewhat lower in IC, but a lot of patients may be accepting of this, but they should be willing to accept the possibility that post-treatment intermittent catheterization may be necessary. Some other get out of the weeds Botox dosing. What I usually will do for patients who are Botox naive, we'll usually start with 100 units, reconstitute into 10 cc's, and we'll focus 25 units in one aliquot on the trigon, 75 units posterior lateral wall in a 0.5 cc aliquots, 15. And then there's a lot of different adjustments we can do here. Change doses, 100 versus 200 on label, versus even some are up to 300. Inclusion or exclusion of the trigone with or without the bladder neck sphincter. Change the inter-procedure interval, and also look at use of pelvic floor Botox injection. Something else, this was in one of our other recent papers, looking at the use of the Botox for the trigone. The trigone actually has a high density of these nociceptive C fibers, which may be responsible for some of the apparent varying pain. And we also have a trial that's still underway, sponsored by the McCormick Foundation of vaginal Botox. You can see our registry number here. Sorry, a small plug. This is still ongoing. Our traditional cystoscopy setup in the OR is what you see on the left. Our innovative approach here involves just the minimal equipment you see on the right and a injection of the Botox. And with this study we're looking at, we're about midway through recruiting. Our goal is actually 12 patients, starting with a 50 unit of vaginal Botox and several correlates with our other basic science work here. And here's one of our other recruitment websites. Some of our next steps with this, we're looking at some of the ROS related pathways, as you heard from Dr. Mohammed, also working with the BG lab and Mallory Labule to look at some of the cytokine induced organoid model systems to test some future hypotheses, and also looking to correlate some of our 24-hour bulk RNA sequencing from our IC BPS urine specimens, also with what we're seeing on our single cell sequencing. We got a question earlier, so I didn't have a chance to respond about neuromodulation. That is also an option. I think it was Jeff from the chat from the first talk. That is also, neuromodulation is also an option. We actually published recently on this, myself and Chris Elliott and my former fellow. And we found that actually there were 6.4% of patient procedures for sacral neuromodulation were performed for the IC indication compared to 20% for OAB dry, compared to overwhelming large 54% for OAB wet. Where I find this is often used, I'm going to skip this slide here, is especially for patients who have flares with their IC. Sacral neuromodulation has some of the stronger data compared to your other techniques like PTNS, but as a management strategy, it can help augment a multidisciplinary approach. And when a patient has a flare, they can turn up their SNS, and then when it gets better, turn it down. One of our former scholars, Sharif Abdallah, we actually just had published Gold Journal. We put together a full series of patients here at Stanford, and over 11-year series of patients treated with PTNS for the IC-BPS indication, and found that pain wasn't a major improvement, but especially a lot of the storage symptoms significantly improved. There was non-significant improvement in pain, which could be something interesting to look at in the future. Major surgery, not going to go into that. We'll thank our prior presenters. And then, getting out to the weeds with cystectomy and urinary diversion, really, a big decision maker for our patients. And we had another question from chat. Sorry, I can't remember who the person was, but asking about comorbidities. Absolutely. A lot of these patients carry innumerable comorbidities, and we really do not take major surgery very lightly. So it's really a small fraction of patients who actually decide to go through with something like this. I'll always talk about risk of persistent pain and cystitis if we leave the bladder in place. Also talk about, maybe I'm using this off-label, the term of phantom pain if we despite bladder removal. And also we need to take into account kidney function to resorb, its potential resorption from the bowel segment, and also ability to self-catheterize, because a lot of patients may have a fear or just a pain associated with some sort of catheterization. And I'm looking forward to Bernardita and Sade. They're in the process of putting together a really great series of our own experience of the cystectomy and major surgery here at Stanford. Treatments not to offer, and this is our second to last slide, don't offer long-term antibiotics, don't offer BCG, don't do high pressure or long duration hydrodistension, and also long-term steroids. All these have adverse effects. So my recommendation to everyone, try and stay systematic, stay objective, and stay out to the weeds. So we talked about, these are our main take-home points. Identify your flare triggers, use a procedure pain scale, localize pain on exam, use a straight catheterization test, get a bladder diary, use these standing urine cultures, really use your AU symptom quality of life scale, numerical rating scale, and set objectives with your pain. These other things here, we talked about the pharmacotherapies and cocktails, who to offer cocktails, tips and tricks about hydrodistension, our cyclosporin, Botox dosing, neuromodulation, and we'll end it there.